very best estimates that are currently available regarding the prevalence of significant, clinically significant emotional disorders among individuals 65 years of age and older is that approximately 15% have significant emotional disorder. Now, given this population of 21 million, this makes an excess of about 3 million elderly who are in need of psychiatric services. There is no doubt then about the fact that there's a big job to be done by mental health professionals.
That was Dr. Eric Pfeiffer, Associate Director for Programs at the Duke Center for the Study of Aging and Human Development.
This conference is designed to provide clinicians working with older people with some new tools and new techniques for practical recognition and management of older patients with mental illnesses. These techniques are available now, but they have not as yet been widely enough disseminated. This conference is, of course, an effort to disseminate such knowledge, and I'm talking here primarily about the total treatability of almost all of the functional disorders.
These remarks are taken from the opening of the National Conference on Successful Treatment of the Elderly Mentally Ill. The conference was held at Duke in late May of 1975. It was the third major national meeting over the past 5 years, organized by the Duke Center devoted to the problems of the aging. Through the medium of this cassette, Wyeth Laboratories and the Duke University Center hope to assist in the further dissemination of knowledge Dr. Pfeiffer referred to.
I want to say that I've become scientifically convinced that elderly people are treatable. What the individual practitioner has to do is to take what diagnostic techniques and what treatment techniques are available now and apply them to the elderly.
In the next few minutes, we'll focus on one of these available existing treatment techniques discussed at the conference, group psychotherapy. Selected portions of the meetings were recorded and discussion leaders were interviewed individually during the conference and after it was over. Dr. Pfeiffer will be our guide to this edited précis of the subject.
I think one of the major points about group therapy with the elderly, as it is indeed for any other age, is that it is not something that one does casually.
We were saying in the workshop today, a lot of people start groups and really are not adequately prepared or realize how difficult it is to run a group with older people. They think that just because people are old, you can put them in a group and age will be the binding force and their wonderful group treatment will evolve. It doesn't happen that way.
Our speaker is Judith Altholtz. She is a practicing group therapy leader here at our outpatient clinic at Duke. During the conference, Judy was co-leader of the workshop on group therapy with Irene Burnside. Irene is a nurse therapist from the Andrus Center at the University of Southern California who also works with older people in groups.
So many of them have such fragile egos already, have such negative views of themselves, that I see group work, one consistent goal, whether it's explicit or not, is that it's an ego-enhancing group. And it should do something for their self-esteem, and it can.
As you can see, it's important for group leaders to establish goals for their group work. But before learning in detail from expert practitioners in this field, let us look at the question of why do group therapy with elderly patients at all? Well, there are some real advantages to this form of therapy. First, it is possible to treat anywhere from 6 to 12 older persons at the same time, resulting in a savings of scarce treatment personnel. But that is probably the least of the advantages. More important is the fact that older patients oftentimes learn as much from older persons in the group as they do from the group leader. And it is amazing how not only the person who learns something, but the person from whom he learns benefits. He benefits because he has been able to be useful to someone else, and that helps. In a group also, the older person learns that other people too have problems like his own. He's not the only one having a hard time. Finally, and perhaps most important of all, group therapy provides an older person with membership in a real social group. As you may know, many older persons have become socially isolated and have lost membership in groups. In group therapy, not only do they become members of a social group again, but the social skills they develop oftentimes allow them to reestablish memberships in social groups outside of therapy. In other words, in the real world. But before you just rush out and start your own group, please listen to some of the complexities involved. Judy, in your workshop sessions, there was a great deal of discussion of the similarities and the differences between groups of elderly patients and groups of younger patients. What are some of the differences that you found?
The whole idea of touching. With a group of younger people, we don't consider using physical touch. It's just not done. You know, in fact, it's a very anti-therapeutic in many cases. With older people, the whole idea of touching, of holding hands, putting your arm around somebody, holding them close to you, is a way of communicating with a withdrawn older person, or a person who can't hear very well, or just needs to be touched.
They need the touch psychologically. I think just the same way as a young baby needs to be touched and handled to thrive, older people seem to need this touching and handling because they don't have other sources. Teenagers may be having a hot love affair. Middle-aged couples maybe have a girlfriend or are married. So they have some source of touching and affection. And when those affectional needs of older people are gone, a leader very often finds herself or himself substituting for the loss of significant others in ways like that. One of the things that I have found very, very useful in group work is to start out with a handshake. That's safe. You know, in America you can shake hands, so that's a good way to start. But a handshake is tremendous in assessing people. For instance, as a nurse, I'm aware of a high temperature. So if a person isn't taking fluids and I feel this hot hand and a warm forehead, I'm aware that either this person's coming down with an illness or is not getting enough fluids, but there's something wrong there. You can feel arthritis, the bumps, and they'll say, my hand hurts today, don't squeeze it too hard. So you pick up pain with the arthritic hands. You can feel the tremor from anxiety, from Parkinson's. You can also, by taking the hand and touching, for a stroke patient who couldn't put his right hand, if you take his left hand, you're saying to him, really, I know you've had a stroke, and I know that hand isn't all right, but this hand's okay. So I find a handshake a good way in every meeting to get very involved. I get very intensely involved before the meeting with each person separately, and I do the same at the end. I say a very personal goodbye, and I don't know if Judy does this or not.
Same thing, yeah.
I have a question here. When you give that kind of personal attention, you have your back to the group. Now, what happens to the rest of the group? Does the group fall apart?
No. These people are very patient. They know their time will come, and they'll sit and wait until you come. So you can do individual things in the group and spend time with one person without the other members feeling that that person's getting more attention. In a younger group, you have to be much more careful about your one-to-one interactions and not focus on them. And I find that you can do it much easier with old people than you can with other age groups.
I agree with that. That's a very interesting point. The other members in the group do not resent someone. In fact, I can remember a woman that came in to a group, a new member, who monopolized the entire hour with this litany of operations and complaints and this and that, and it was just horrible. I was bored to death, and the other leader was bored, and I thought, this is terribly destructive, you know. And after it was over, after the group was over, everybody said, you know, that was really important because it was so important to that lady to tell us all the problems she has had, and I'm so glad she got a chance to tell somebody, because obviously nobody else would listen to her. They were not disturbed, they were not upset, they didn't feel cheated, they felt it was important for this lady to tell her problems, and they gave her a lot of support for her problems, which may not have been so therapeutic, but it was amazing. With a group of younger people, that wouldn't have occurred.
Yeah, the other thing they can tolerate very well in groups is silence. We have been so conditioned to verbalize everything that we feel that 1 hour we must be talking and talking in such and such a fashion. Old people don't seem to have that same need. They can tolerate silence, they can tolerate a monopolizer, and the tolerance of each other's behavior, I think, is one of the things that is a rewarding thing in doing group work.
It is. They seem to sense that there are certain people that come to the group that are not verbal, and this particularly happened in one group, who were not verbal for a number of reasons, but they got a lot out of just being there, just sitting there for an hour. And there was never any pressure put on those members to talk or to verbalize.
That's one of the real differences in groups of older people and younger people, because they very often will get angry with the silent member in the younger groups that I've been in, and they say, you know, you've sat through 3 group meetings now and haven't said a word, you know, and they really express anger. Old people do not express that same kind of anger at a silent one. In fact, I've heard them make excuses and say, well, you know, since her stroke, it's been so hard for her to talk they sometimes acknowledge even the reason or what's behind it to make it easier for that person. It's like, it's okay, I understand why you don't feel like talking today.
All right. You've said that working with older patients in group therapy is different in certain respects from working with younger patients. You've mentioned the fact that touching is permitted, that you can deal more intensively on a one-to-one basis with individuals in the group, that periods of silence are easier to work with, and you've mentioned the tolerance older people exhibit towards others as compared with younger groups. Why don't you go on and talk about some other differences?
The use of reminiscing, which is based on Robert Butler's work of the Life Review. Old people like to reminisce, and that it's an adaptive quality to aging and should be encouraged to do so. So the use of reminiscing in group work with the aged is a very important component that may not be in other groups. Another aspect is the tremendous amount of losses they've experienced across their lives, and the group leader is always somehow substituting or trying to help them compensate for loss, but you're always dealing with the theme of loss in group work. And two elements. The sensory deprivation that many old people feel, whether they're in the community or in the hospital, they are sensorially deprived, and they need this stimulation. And the other thing is that the sensory deficits of vision, the hearing, touch, the leader has to be terribly tuned in to what sensory deficit does to people. Like Eisdorfer's study on hard of hearing old men are more suspicious and have more of a tendency to parent. It behooves a leader to know that, because he or she will know how close to move in. But there's so much in the area of sensory stimulation and sensory deficits that we don't really know a lot about. And a leader does not have that with younger kids or with middle-aged people. You aren't coping with that
Constantly.
But every older person isn't suitable for group therapy. Have you found patients for whom this is an inappropriate form of treatment?
We had an uncontrolled manic depressive older woman in our group that was terribly, terribly destructive to the group.
I think that's where making the contract and really interviewing and screening your people before the group. I had a similar experience as Judy. I had taken in a woman who was more brain damaged than I was aware of. Watching her and talking to her, I didn't realize that she was quite as bad. I should have spent more time with her before I even took her into the group.
We also had someone who was so terribly hard of hearing, even with a hearing aid, that it was finally the man had to stop coming because he could not hear what was going on. Other members felt very guilty because they wanted him to be brought in, but the only way he could hear was if you sat 2 inches from him and screamed at him. And it just didn't work out. It raised the anxiety of everyone.
And another kind of person that I have had trouble with, and I don't know about you, Judy, is the loner. I had a man in the group for 34 meetings who had been a loner all his life. When his birthday came, we had a birthday party, which he really seemed to enjoy, and we had cake. But the group got too close to him, and he couldn't tolerate the closeness, and for no reason at all. There was no legitimate reason for him dropping out. He simply couldn't handle it, and I feel sure that for that type of person who has always been a loner, and at the age of 75, we try to put them into a group that is becoming cohesive. They cannot tolerate it.
The other problem that we found was persons who are very depressed have a lifelong pattern of depression. They are now older people who cannot tolerate any anger, cannot tolerate expressing any angry feelings to anyone. We tried someone like this in the group who was very depressed and who was so annoyed with another group member with whom he had every reason to be annoyed. The man was very irritating. And this particular depressed gentleman finally, with a lot of support, got angry at this annoying man. He then became so guilty about getting angry and expressing his anger that he, of course, turned it in on himself and became terribly depressed, even worse than he was, and refused to come back because he saw no reason to get more depressed than he was. He had been this has been his pattern for 70 years, and I don't think we could change it.
Well, but depression is by far the most common emotional disorder we see in persons in later life. You don't mean that if you make the diagnosis of depression that rules out group therapy for the patient, do you?
On the contrary, I would recommend group therapy, but I think you have to look at the kind of depression you have. Is this a depression of late life? Is this a chronic depressed person for the last 70 years? They've been depressed, and they can't face anything. They can't deal with anything. On the contrary, the first group we ran for 2.5 years, and the reason these people were chosen for the group was that they, A, had a diagnosis of depression, That was one of the primary reasons we had them in the group. And we got a mix, though. It's very important. If you're going to have depressed people, you must be very careful to get a mix. Otherwise, you're going to have 8 people sitting around, just sitting, looking at each other, looking sad and terrible and depressed, and it's going to be just very awful. You need a mix. What kind of living situation? Rest homes, private homes, wealthy, not so wealthy. Although some people have said that they don't like to mix incomes too much. It has never really bothered me. Talkative people, not, withdrawn people, people who had families, people who were alone. You have to get some kind of a mix, otherwise you're going to have a depressing group. And you don't want a group to be a depressing experience. You want to talk about happy things, not just problems.
This is the end of side 1. Please turn your cassette over. Side 2. Here again is Dr. Pfeiffer.
What about a mix in age? Would you recommend mixing 50-year-olds and 80-year-olds?
I have never mixed young people meeting under the age of 55 with older people.
Nor have I. In fact, I've tried very hard to work with the old, because they are the most neglected ones. The 70, 80, 90, and 100-year-olds, I really think have been pretty much neglected in the therapeutic realm. So I've really tried to work with that age group. In fact, I throw out a 50-year-old if they try to put anybody in the 50s in the group. Their energy levels are different. Sometimes the attention span is different. So that for me, there's just too much of a difference. And the 50-year-old has a different set of problems, and I find it very difficult to get the very young ones in there.
Okay. So we've said that lifelong, severely depressed patients are probably not good candidates for group therapy. Certain kinds of sensory deficits may be just too big a problem to handle in a group. And severe organic brain syndromes are probably also not suitable. Now, I have another question for you. What about the therapist himself? Can anyone who can do group therapy with younger people do group therapy with older people? What kinds of qualities should the group leader have?
There's an salty old sea captain once said, to get along in this world you have to be limber, loving, and a little bit loony. And I think you have to have those 3 qualities to work with old people. I think maybe we need to look at some of the qualities. Judy, you come to them.
You must, as a group leader with older people, more than any other age group, I think, feel very comfortable with yourself and very secure with yourself, because they're going to ask you personal questions, and they're going to give you things, and they're going to put you, they're going to embarrass you and test you. And you have to feel very comfortable and very secure. They test you so beautifully, Judy. When you start a new group, they invariably find out how you handle death or dying, because that'll come up early. Something will come early. They also find out very quickly how you handle sexuality, because they'll throw some little things in to find out if it's going to be okay to talk about sex. So in their own way, they test you to find out how you're going to handle things in the group, and if it's going to be okay for them to talk about that. And they do this very, very subtly sometimes. Very. We've mentioned a lot of the problems of group therapy. We really have never said that group therapy with old people is fun. It is fun. It's hard work, and we've mentioned all the negative things about it, but it can be fun too.
The learning that you get from it as a group leader is the kind of learning that you'll never get in the library.
Right. The way they've managed to cope with all that's happened to them has really changed my outlook. And just have learned a lot from older people, in groups particularly. A whole different perspective on the life cycle, I think, and serenity about, it sounds very melodramatic to say serenity about death, but feeling much more comfortable.
Right. I can name 3 areas that I know I have changed in just being a group leader of old people. One is my tremendous respect for them, for their concern, not just for themselves or their family, but for the world. They will pray for you, they will be concerned about you, they will love you when they're in pain. And they have a global concern that I don't see in other groups. The second thing that I have found out about group leading is that old people are very generous about letting you be you. We've all been taught to be so professional that this behavior is appropriate and this isn't for a group leader or a professional whatever. But old people are such individuals themselves and have struggled so hard all the years to maintain their own uniqueness that they give you the chance to be you. And I don't have the feeling that they're trying to change me or that they want me to behave differently. So there's a freeing up of yourself as a person, and it's a professional. And the third thing is that I used to think it was a one-way street, and I was forever giving to them, and I was the nurturing one. It comes as a real surprise when you find out how nurturing old people are. For instance, you can go into a group and say, I'm terribly tired today. And they will start to lift and pick up and support you, be concerned about you, and in the next meeting will ask you, are you as tired as you were last week? And I think we deprive them if we don't let them give us something, and they need this chance to barter and care. Even giving gifts, I found out that very often they need to pick a flower and give you, they need to give you something.
So many older people have told me that what they miss most of all is being needed. Nobody needs them anymore. You know, society doesn't need them, their kids don't need them, nobody needs them. And when you as a group leader can show that you still need them, you know, it's a tremendous experience.
The other thing I think we take away is their ability to give gifts. We say, oh, you keep that, you need it more than I do, or you shouldn't be spending money, and we put them down. I remember a man, now maybe he didn't like bananas, I don't know, but he used to save the bananas on his tray for me. That was his gift to me. And another man gave me a calendar, he said, I can't read it anyway. This ability to receive what they give, because they can no longer barter if they don't have much money, and so that they can give a leader something, and that seems to be very important to them. It goes back to, my life doesn't have much meaning, and you know, nobody needs me.
I think it's very important, and I think to reject those gifts can be very destructive. Again, this goes back to the quality of a group leader. It's interesting how many people who work with professionals, who work with older people, have had good experiences with family members who are old. This is often very important.
I think tenacity is another thing, and gentle. Old people are pushed and shoved around and really almost manhandled sometimes. They're yanked and pulled. And there's a gentleness that is required in working with old people that a lot of people just don't have. They're too brisk, they're too rapid, they can't pace themselves.
As well as really liking old people, you have to have a respect for old people.
Yeah.
If you have the attitude that you are going to do something to these old people, that's a very destructive attitude, because you are simply echoing what everyone else is saying. You as an old person no longer have any dignity, you no longer have any intelligence to make your own decisions. I, as the professional, am going to tell you what is good for you, and I am going to show you what is good for you. You must be very committed, as with any age group of course, to working with the older person, not to them.
The other thing is that it's a tremendous chance to look at a world that I never knew. When they start reminiscing, and it's too bad that much more of it isn't recorded, because things like, one man I remember described his honeymoon in a covered wagon. I've heard about the San Francisco earthquake. Right. They have fabulous stories to tell, and so often there's nobody to listen. I feel like I've been enriched. On the reminiscing days, it's like a venture back into history.
I love it. I'll just sit there for hours and listen to them. Just hours.
A lot of times their anguish is relieved too. If they've had guilt feelings about a brother or a sister or a sibling or their folks, it's amazing that the feelings that come out, the sadness, they're able to say how sad they felt. A lot of feeling content can come through reminiscing. It's not always the happy good old days. They are willing to reminisce about the sad days, and sometimes a leader isn't really willing to listen about the sad old days.
Right. Right. I think group therapy allows older people a chance to help each other with some solutions. Things like when you can't remember somebody's name, when you have memory loss and you forget people's name constantly, and forget the day or whatever, how do you handle it? Well, I'm relatively young, and I have, of course, some memory loss myself, which is becoming more pronounced. But they can sit around and they say, well, look, this is what I did, or this is what I did. And they can help each other develop solutions to problems from their own experiences.
These people have so much stored up of ways to problem solve and lived through several wars, the Depression, and through such hard times. Their problem-solving ability is really excellent, and I don't think is capitalized on. Professionals say this is what you should do. We helpers are going to show them. If we let them come up with the solutions, their solutions are just far better than ours most of the time. Right. And they do come up in group. The solutions come up in group.
Listening to Judy and Irene discussing their experience, it seems to me that something else besides the specific aspects of treatment, like group therapy, comes through. What also comes through, it seems to me, is a wider awareness of the social situation in which this treatment takes place, a clearer view of the cultural framework within which most of us are bound. And before closing this program, I should just like to give you a brief glimpse of that social situation as seen by our resident expert in that field at the conference, George Maddox.
In the absence of debilitating organic illness, intellectual functioning remains quite stable well into the 7th decade of life. Men are not automatically destroyed by retirement, nor women by having their last child leave home, as the popular image would have it a decade ago. Involuntary retirement and exclusion of women from the workplace in late life reflects social arrangements, not rules of nature. Some individuals seek early retirement and alternative careers, and many parents whose children have left home perceive this not only as appropriate, but as liberating. And if there are any of you here with teenage children, you may know what I'm talking about. Most older people can and do maintain a high level of involvement in community organizations and affairs. They remain as informed and as involved in political affairs as adults generally, and are a relatively untapped source for participation in voluntary community organizations. We now know with certainty that nature does not dictate that older people must be uniformly poor, sick, impaired, depressed, inactive, and isolated. There is no way to make the lemon of life totally sweet. Death is inevitably the fate of us all, and with age, there is increased risk of physical and psychological impairment as well as personal and social loss. But to a substantial degree, the personal and social poverty or the richness of late life reflects less what older people are than it does the opportunity society makes available to them.
And I would argue, as George Maddox often has, that the opportunities society makes available to them are, in the last analysis, the opportunities we provide for ourselves.
I keep saying to you, as I say to my colleagues, do not talk about those older people as though they have nothing to do with you. We're not talking about those old folks. We're talking about the world you are about to inherit as well as theirs.
I believe we medical professionals must rethink and re-examine some of our traditional assumptions about treatment of the medical and psychological problems of the elderly. In doing so, it may be that we shall discover that they are really us.
Thank you, Dr. Pfeiffer. This audio cassette tape series on the successful treatment of the elderly mentally ill is brought to you by Wyeth Laboratories and the Duke Center for the Study of Aging and Human Development as a service in continuing education. Participation by discussants on this tape does not imply endorsement of Wyeth products, and the opinions expressed by discussants are their own. Other tapes in the series deal with individual psychotherapy and the somatic therapies as they apply to the elderly. We hope you'll find them useful.